So we are dealing with fever in infants, right? And fever is usually controlled by the hypothalamus. So that was what I was talking about. The hypothalamus is that portion in the image which we are using the red arrow to point to. Remember that the Canadian exam does not go into anatomy and biochemistry and physiology like the USMLE step 1. So forget about all that. Basically, I'm just using this as a teaching point for you to appreciate the fact that fever is controlled by the hypothalamus. Now, it is the hypothalamus sets what we call a thermal set point, right? And this is as a result of pyrogens. So pyrogens are the causes of fever. So just think about it this way. We have external pyrogens and we have endogenous pyrogens, or we have exogenous pyrogens and endogenous pyrogens. So exogenous pyrogens are just things which are coming outside of the body to affect the body for the body to have fever. So things like bacterial infections, things like microbial products, even some antibiotics, some medications can cause fever, right? And endogenous pyrogens are the stuff in our bodies which the body will produce as a result of, something going wrong. So things like interferon gamma, thymonecrotic factor alpha, interleukin 1, interleukin 6. Don't worry your head about these things. This is just an introduction to everything I'm going to talk about today. Okay, now I'm going to give you a first question. Which of the following differentiates fever from hypothermia? You need to be able to tell the difference between fever and hypothermia in the MCQ one. So I'm going to make the screen bigger, and then you will tell me which of the following differentiates fever from hypothermia. A, presence of elevated body temperature. B, one is triggered by infection. C, there's a change in the hypothalamic set point in one of them. D, response to antipyretics. And E, involves vasodilation. Okay, so which of the following differentiates fever from hypothermia? A, the presence of elevated body temperature. B, triggered by infection. C, change in hypothalamic set point. D, response to antipyretics. And E, involves vasodilation. Doctors, it looks like everybody got it wrong. The correct answer is C. C. Remember that we said that fever is controlled by the hypothalamus. Now, hypothermia occurs when the body's ability to ward off excessive heat is overcome. So you realize that fever is controlled by the hypothalamus, but hypothermia occurs when heat dissipation mechanisms fail. That is when hypothermia occurs. So please make sure that you know that very well. Okay, so the correct answer is C, not B, not D, not A. A lot of you went for that, but the correct answer is C. Okay, I have another question. You have a 2-year-old child who presents with fever. Which of the following statements is most accurate regarding treatment? A, antipyretics are required to prevent febrile seizures. B, fever must be aggressively reduced below 37 degrees Celsius. C, treatment is aimed at relieving discomfort, not normalizing temperature. D, antibiotics should always be given with fever. And E, cooling baths are recommended for rapid reduction. What's the correct answer? What's the correct answer here? So what's the correct answer? I see that Dr. Mosima says antipyretics are required to prevent febrile seizures. Dr. Lamia also says that is E, cooling baths are recommended for rapid reduction. And Dr. Benny rather went for C, which says treatment is aimed at relieving discomfort, not normalizing temperature. Any other answers? Dr. Rockefeller went for A, antipyretics are required to prevent febrile seizures. Look, the correct answer to this is C. C. Treatment is aimed at relieving discomfort, not normalizing temperature. You realize that the primary goal of antipyretic therapy in children is comfort. Fever itself is part of a beneficial immune response. So the main reason why you're giving the antipyretic is to bring the child to a set point, so that the child is comfortable. And when that set point is reached, fever itself will be controlled. Okay, so now let's go to this thing, measuring fever in infants. And after that, I'm going to dial back in the MCCQE one. I need you to write this in your books. You need to master 3 categories of children that you are going to learn how to manage their fever in terms of investigations, in terms of, management. Number 1, I need you to write this down because I didn't write it in the notes. Number 1, the first group of infants you need to learn is newborns to 28 days of age. Whichever book you are using, whether you're using Tintinali, whether you're using Toronto Notes, whether you're using Master the Boards, you realize that you need to master. There are some unique things which come with various age groups in terms of investigations. Is it everybody you're going to do a full septic workup in, right? So the first group of people I need you to master, and we'll be focusing on them today, is birth to 28 or 30 days. The next group I also need you to master will be from 29 days to 1 year of age. And then the other group is from more than 1 year of age upwards. And the place that a lot of people get tricked is fever in the first 28 days. And that is why I'll be focusing on very soon. So please make sure that these 3 things I mentioned, you are following them. Number 1, fever. In fact, let me just copy that in the comment section. Fever in children who are less than 20 or who are 28 days, newborn to 28 days. And then I've put it in the comment section. And then 29 days to 1 year. And then children who are more than 1 year. So you realize that you have to learn from newborn to 28 days. We call them neonates. So you have to learn fever in neonates. Then you go on to learn fever in infants from 29 days to 1 year. And then you go on to learn fever in children. That is from 1 year and above. Doctors, please, you need to pay attention to this very well. This nomenclature, all right? But first, let's talk about measuring fever in children, because you need to master this as well. Now, which method provides the most accurate measurement of core body temperature in infants? Which method provides the most accurate measurement of core body temperature in infants? A, oral thermometry. B, axillary thermometry. That is in the armpit. C, rectal thermometry. D, tympanic thermometry. And E, temporal artery thermometry. So in other words, if you want to measure the core body temperature of a child, Which of these gives you the best and the most accurate method of doing that? Is it checking it by the mouth? That is oral thermometry. Is it checking it through the armpits? That is axillary thermometry. Is it rectal thermometry? Is it going through the ear, tympanic thermometry, or just going through the temporal artery thermometry? Which of them? And I see a lot of doctors going for C. And that is the correct one. C is the correct one. Rectal measurement is the reference standard for infants and young children. Axillary and tympanic methods are less reliable. So if you want to actually get core temperature in a child, use the rectal thermometry. Then I'm going to ask you a follow-up question to that. Since we are saying that rectal thermometry is the best to measure core temperature, now this is the next question. Which of the following situations represents a contraindication to rectal thermometry? Which of the following represents a contraindication to rectal thermometry? A, fever more than 39 degrees Celsius. B, diarrhea. C, neutropenia. D, otitis media. And E, tachypnea. Now that you've told me that rectal temperature is the best way to measure core temperature, now I need you to help me with this one. Which of the following situations represents a contraindication? This one you must know it. Contraindication for rectal temperature measurement. Is it fever more than 39 degrees Celsius? Is it diarrhea? Is it neutropenia? Is it otitis media? Or it is tachypnea? What is the correct answer? I see that there's a confusion between B and, I will not give the other one, B, A, C, D, and E. What is the correct answer? Doctors, the correct answer is C, neutropenia. And there's a reason. Why will you not want to stick a thermometer in the bum of a baby who is neutropenic? Maybe the baby is being treated for a form of cancer, or the baby has an immunosuppressive state. Why? The reason is because in neutropenic patients, rectal probes can cause mucosal injury and sepsis. Don't forget that this child is already neutropenic. This child's immune state is low. Now, the rectal temperature measurement, one problem with it is that it can cause bruising in the rectal verge. Also, don't forget that in the rectal region, there are so many bacteria there. So the thought is this, that if you do a core body temperature with a rectal measurement, and then there's a break in the continuity of the skin, what can then happen is that you can introduce some of the organisms in the rectum through the skin into the child's bloodstream, and that can lead to sepsis. And sepsis in a neutropenic patient is not good news. Sepsis in a neutropenic patient is not good news. Doctors, please, are you picking the points I'm laying down today in the class? I really want to know, are you picking up the points that we are laying down? Because these principles are very important if you want to ace your board exam. So you realize that you go like, oh, fever in children. Oh, I think I know everything about fever in children. But now we start digging into specific things, and you get to know that, no, I need to study more. I need to really know these things. Okay? I need to really, really see and understand these things. Okay, so let's go to the next point. A caregiver measures a child's temperature with a temporal artery thermometer and obtains a low reading. Which factor most likely interfered with accuracy? So remember those thermometers that you go to the hospital and then they go across your forehead? Now, a caregiver measures a child's temperature with a temporal artery thermometer and obtains a low reading. Which factor most likely interfered with accuracy? A, eating cold food. B, tachypnea. C, sweating, D, recent vaccination, and E, dehydration. Is it A? Is it B? Is it C? Is it D? And I see a lot of doctors going for C, sweating. So forehead or temporal thermometry is affected by sweating and changes in cutaneous blood flow. Okay, so that is something you also want to learn. Okay, good. So I want to make a point about measuring body temperature because we've gone through a lot of questions about that. Now, body temperature can be measured at several sites: the rectal region, the mouth, the axillary region, the ear, that's the tympanic membrane, and the forehead. And each size has its own normal range and its limitations. And understanding these is key for accurate interpretation, especially in pediatric fever assessment. Right? Now, rectal temperature. So this is where I'm teaching about the question I gave. Is the gold standard for core body temperature. The gold standard. It is used in infants and young children. Typically, the rectal temperature is higher than the oral or axillary readings. Now, what's the contraindication? It is contraindicated in neutropenic patients because of the risk of mucosal injury and further infection into the whole body, like sepsis. Now, there's a lag between changes in core body temperature and rectal readings, but the main thing I want you to pick from this slide is that I will not do rectal temperature measurement in a child who is already neutropenic. I will not do that. Okay. Now let's go to oral thermometry. It is suitable for older cooperative children, right? Usually it is about 0.6 degrees Celsius lower than rectal temperature due to mouth breathing. And it is affected by the child eating hot and cold liquids. And it can also be affected because of tachypnea. One thing you need to learn about oral thermometry for your board exam, the MCQA one, is that it is not reliable in children less than 4 years because they don't cooperate. So, contraindication for rectal thermometry is neutropenic children. Oral thermometry is not reliable in children who are less than 4 years. These are pearls you need to know for your exam. Okay. What about axillary thermometry? It is the least invasive, but least accurate. And its values are consistently lower than the rectal, but the gap is variable. Okay. And so if you have a neutropenic patient or an uncooperative patient, like that child who is less than 4 years, who will not take an oral thermometer, or you have a neutropenic patient, a child who has a form of cancer, therefore you don't want to check the temperature from the bum, the best option will be your axillary temperature. So you see, these are the nuances you need to learn in order to be able to ace your exam. You can use it for children who are less than 4 weeks of age, right? Because you can just put it there and then hold a hand close to it. Okay. So I have a question for you. Which of the following best explains why infants tend to have higher normal body temperature than adults? Which of the following best explains why infants tend to have higher body temperature than adults? A, they have greater water content. B, they have immature sweat glands. C, they have higher surface area to body weight ratio and metabolic rate. D, they have a larger hypothalamus. And E, they have faster respiratory rate. Okay, so the correct answer is C. They have a higher surface area to body weight ratio and a higher metabolic rate, right? And so infants lose more heat easily and must produce more to maintain their normothermia. So the correct answer is C. C. Now, you have another question. You have a 2-month-old infant who presents with rectal temperature of 38.2 degrees Celsius. Which of the following is true? Which of the following is true? A, no workup is needed if the child looks well. B, this represents fever of concern requiring evaluation for sepsis. C, this is normal for age. D, give acetaminophen and observe. And E, fever is defined only above 39 degrees Celsius in infants. What's your correct answer here? You have a 2-month-old infant. So 2 months is like 60 days. Presents with rectal temperature of 38.2 degrees Celsius. Which of the following is true? A, no workup is needed if the child looks well. B, this represents fever of concern requiring evaluation for sepsis. C, this is normal for age. D, give acetaminophen and observe. And E, fever is defined only above 39 degrees Celsius in infants. So I see a lot of D's. Like it looks like the answers are spread all over. Dr. Benny says A. Dr. Sharika says, Dr. Joanna De Cruz also says A. Dr. Taiwo says D. Dr. Mark Ada says this is normal for age. That is C. Dr. Victor Williams says D. Give acetaminophen and observe. Dr. Salihu Kwara also says D. Give Tylenol and observe. Dr. Benedicta says D. Give Tylenol and observe. What's the correct answer? It is B. Any rectal temperature of more than 38 degrees Celsius in infants who are less than 3 months of age mandates what we call a full septic workup. So this is what I was talking about. You have to know how you're going to manage a child who is less than 28 days, those who are between 29 to 1 year, and even the 29 to 1 year, there's at times a distinction, 29 to 3 months, then 3 months to 1 year, and then 1 year and above. Okay, now this is what you have to understand. Any rectal temperature of more than 38 degrees Celsius in infants who are less than 3 months of age mandates a full sepsis workup. Please pay attention to that. That is B, full sepsis workup. So now let's focus on children who are less than 3 months of age, which is very, very important. That was what the question was about, right? Let's focus on them. Fever in these children. Doctor, I have a question. Are you getting a better perspective of what we are dealing with now? So it's not enough to say I've learned fever. You need to know the various categorizations, the various ages, and how you're going to manage them. Which of them are you going to do a full septic workup? In the full septic workup, which tests should you do for every infant so far as they are less than 3 months of age, no matter what? These are the things you need to learn and pick up for your exam. Okay, awesome. So let's go. I have another question for you, because we'll do some questions before I dive into the deep study. So you have a 21-day-old infant who presents with rectal temperature of 38.3, poor feeding and irritability. What is the next best step? A, give acetaminophen and recheck later. B, performs full sepsis workup and start empiric IV antibiotics. C, observe the patient at home. D, obtain urinalysis only. And E, discharge with reassurance. What's the correct answer? And doctors, please, while you are here, kindly click on the like and subscribe button on our YouTube channel. Please, we are growing this channel with you. We are currently at 3,500 subscribers. We want to get to 4,000 subscribers. Please click on the like and subscribe button so that whenever we drop any video, you will see it right away. Okay, so please, what's the correct answer here? A 21-day-old infant presents with rectal temperature of 38.3, poor feeding and irritability. What's the next best step? Give acetaminophen and recheck later, full sepsis workup, observe at home, obtain urinalysis only, and discharge with reassurance. The correct answer is B. You want to do a full septic workup and start empiric antibiotics in this baby. Any neonate less than 28 days, in fact, any neonate less than 3 months will require an immediate full septic workup and hospitalization so far as they have fever. Okay, so next question. A 6-week-old infant presents with fever of 38 degrees Celsius but looks well. So 6 weeks is like 1.5 months. Which test must always be included? Beautiful. I like this question. Which test must always be included? A, blood culture only. B, chest X-ray. C, urinalysis and urine culture. D, head CT scan. And E, lumbar puncture only if the child is ill appearing. This is a beautiful question. You have a kid, 6 weeks. Temperature is 38 degrees Celsius, but the child looks well. Which test must always be included in this group of patients? Oh, Dr. Rockefeller, you're making me happy. You're making me very, very happy. He went for urinalysis. Urinalysis. You have a kid, even though the kid looks well, but the temperature is high. Which test must you always include? Urinalysis and urine culture. Because UTI is the most common severe bacterial infection in children between 1 to 3 months old and must always be ruled out in all cases. UTI. You must rule UTI out in all cases, please. Always remember that. You must rule UTI out in all cases of children who are less than 3 months of age. Okay. Next question. And this one may trick some people, but let's try it. Which of the following findings most strongly suggests meningitis in neonates? Because when it comes to fever in children, meningitis is one of the differentials we don't want to miss, right? Now, which of the following findings most strongly suggests meningitis in a neonate? A, neck stiffness. B, bulging fontanelle. C, hypothermia. D, cough. And E, diarrhea. Which of the following findings most strongly suggests meningitis in a neonate? A, bulging neck stiffness. B, bulging fontanelle. C, hypothermia. D, cough. And E, diarrhea. And I'm very happy. Almost everyone is going for bulging fontanelle, and that is the correct answer. Neck stiffness is rare in neonates. Bulging fontanelle and irritability when the child is handled is a key sign of meningitis. Exactly. It's a key sign of meningitis. So you want to pay attention to that. Okay. Another question. You have a 2-month-old infant with otitis media, ear infection, and the child is found to have a temperature of 38.5 degrees Celsius. what should the doctor do next? Or what should the clinician do next? A, treat only the ear infection, 2-month-old. B, order full sepsis workup. C, reassure the parents. D, schedule follow-up in 48 hours. And E, start oral amoxicillin and observe. What's your correct answer? What's your correct answer? Treat only the ear infection, order full sepsis workup, reassure the parents, schedule follow-up in 48 hours, and start oral amoxicillin and observe. What's the correct answer? Now it looks like everybody is picking up the principles we are laying. So even if a source like acute otitis media is present, occult bacteremia or UTI can coexist so far as the baby is less than 3 months. Please do your full sepsis work up. That's the correct answer. Now, next question. Next question. Which organism is the most common bacterial cause of fever in neonates? Let me ask again. Which organism is the most common bacterial cause of fever in neonates? A, Listeria monocytogenes. B, Group B, Streptococcus. C, Strep pneumo. D, Neisseria meningitidis. And E, Haemophilus influenzae. The participation in the class is through the roof. And I really, really enjoy it. When you participate, that is what gives me energy. Doctors, please don't forget to click on the like and subscribe button. Smash on that. Smash on the MedCognito subscribe button right away. And let's get the ball rolling. Okay. So which organism is the most common? And the correct answer is Group B, strep. So the answer is B. B. Group B, strep. Group B, strep. Okay. So GBS is the leading cause of neonatal sepsis and meningitis, followed by E. coli and Listeria. So if you are listing the common organisms which cause fever, neonatal sepsis in children, newborns, Group B, strep. That is why we do the swab in the mothers around 35 to 37 weeks, right? So that if it is there, we preempt it because the kids can pick it up when they are coming to the vaginal canal during birth, right? Beautiful. So now that we've gone through these questions, now we're going to get into the topic itself. Overview of fever in children less than 3 months of age. Now, the first thing I want you to understand is that fever in infants less than 3 months old is a medical emergency until proven otherwise. Let me say it again. Fever in infants less than 3 months old is a medical emergency until proven otherwise. And these infants are at high risk for serious bacterial infection. That is why, if you remember in the questions, even though the child is, say, 2 months and the child has obvious ear infection, you want to do some further septic workup to check, right? Don't just say, oh, it's a simple ear infection, so you can go home with some amoxicillin. No, these infants, that is those less than 3 months of age, are at high risk of serious bacterial infection because of their immune defense, which is immature, and often non-specific presentations are seen when they are going through an infection. So, what are the factors? Number one, the gestational age and birth weight. When you take full-term infants and premature infants are at higher infection risk. Okay? Now, peripartum antibiotics, children whose parents or whose mother received antibiotics around the time the baby was born. Or if the child itself was started on antibiotics right from birth. This may mask neonatal sepsis. And what about perinatal complications like chorioamnionitis, prolonged rupture of membranes, right? These increase the risk of infection. Yeah. So learn these risk factors: prematurity, peripartum antibiotic use, perinatal complications like chorioamnionitis, prolonged rupture of membranes. Now, what about the timing of onset? If the fever starts less than 7 days of age, often it's as a result of perinatal sepsis. If the fever starts after 7 days of birth, it's as a result of community or nosocomial infections. Maybe they picked the infection from the hospital, or they picked it when they went to the community, when they went home. Because usually in Canada, unless like there was a complication in the delivery and the child needs to be in the NICU, or maybe the mother needs to stay in the hospital for some time, usually within 24 to 48 hours, the mother is sent home after the initial metabolic workup is done and the ear testing and all those things are done, right? Now, neonatal complications, tachypnea, jaundice, they may have feeding issues. When you see a child who is presented in your board exam with these things, please start thinking about the possibility of sepsis or congenital infections. Okay, so what are the common presentations of fever in children who are less than 3 months of age, which at times may not be so obvious? So there are some non-specific features. One of them is irritability. You realize that the child is very irritable. Yeah, the child is very irritable. They may be lethargic. They may feed poorly, so they may not be latching onto the breasts very well. They may be vomiting. They may have diarrhea. These point to badness in these children, right? It could also be as a result of an alternative diagnosis like colic, like viral infections, like an early urinary tract infection. And they may also present with tachypnea and hypoxemia. When you see these symptoms, start thinking about pneumonia in that child. And then they may have bulging or full anterior fontanelle. We learned that. It may suggest meningitis. And in neonates, always remember that neck stiffness is a bit rare in them. Okay? Yeah. And then they may also present with, crying. They're so irritable. They are inconsolable even when they are crying. When you see that, it's a very, very, very strong clue for meningitis. And then you can also look at their skin exam. You look for redness, which may point to cellulitis. You want to look at the umbilical stump. So you want to check for umbilical infection. You want to check for a vesicular rash, possibly as a result of HSV, right? And then never forget to look into the ears. Look into the ears and look into the throat, because they hide a lot of infections there. Because that can be pointing to acute otitis media. The other thing you have to understand is that normal vital signs in a kid with all these nuanced presentations does not mean that there is no sepsis. The kid can have sepsis and have normal vital signs as well. So your antenna must go up, ping, when you are dealing with these kids. Now, physical exam. Remember the MCCQE1, when you're preparing for it, you have to prepare for it with a six-prong approach. Six-prong approach, and that is why I'm going through all these. History, physical exam, investigations, management, complications, and disposition. Every case you take. So if it is chest pain, you must know the various causes of chest pain, how they present on history, how they will present with physical exam, how they will present with how you will investigate them, how you're going to manage them, what are the complications and disposition. Which chest pain patients are you going to send home? Which chest pain patients are you going to call the cardiologist right away? Which chest patients are you going to give? So every topic you are dealing with, look at it from this six-prong approach: history, physical exam, investigations, management, complications, and disposition. You realize that every MCCQA1 objective focuses on these 6 points. So we are talking about fever in neonates. Now let's talk about physical exam. In every neonate, you want to do a head-to-toe exam. The general appearance of the baby. Is the baby irritable? Is the baby lethargic? Vital signs. Look for tachypnea. Look for hypothermia. Look for bradycardia. That's dangerous. On the skin, look for petechiae. Look for purpura. Because if you see purpura in a child with fever, start thinking about the possibility of meningococcemia. So it looks like the meningitis has now gone systemic, right? Look in the ear, the nose, and the throat for otitis media, nasal congestion, even the throat. On the chest, look at signs of respiratory distress. Are they using extra muscles for respiration? Are they having nasal flaring? Are they having, issues with their sternocleidomastoid? Are they having lower chest indrawing? On the abdomen, look for abdominal distension. Look for tenderness of the abdomen. These should point you to possible necrotizing enterocolitis, especially if the child is a preterm, right? Urinary tract infections. Look at the fontanelle. Is it bulging? Is it sunken? If it is bulging, think about signs of meningitis. If it is sunken, look for other areas on the body where you can pick up dehydration, where they are crying but their tears are dry. You look at the skin tinting, right? Their eyes may be sunken. They point to dehydration. But bulging anterior fontanelle, think about meningitis. You want to look at their genitalia. You want to check, the circumcision site. So you've not evaluated a newborn baby or a baby who is less than 3 months of age very well until you strip that baby and look from head to toe. Look at the skin, look at all the various crevices, do a neurological exam, check their tone, check their cry, check their responsiveness. Now that we've looked at that, let's now look at the common causes of fever in children who are less than 3 months of age. So bacterial pathogens, please know these ones. Know them. Group B streptococcus. E. coli, number 2. Listeria monocytogenes. Number 4. Strep pneumo. Number 5. Neisseria meningitidis. These are the common organisms which cause fever in children who are less than 3 months of age. And the commonest one is group B strep. Let me say it again. The common organisms you need to know for your board exam and for your practice: group B strep, E. coli, Listeria monocytogenes, Streptococcus pneumoniae, and Neisseria meningitidis. Now, for the viral organisms, think about enteroviruses, think about HSV, think about respiratory syncytial virus, and think about influenza. Yeah. Why will a child have fever? Why will a child who is less than 3 months have fever? You've looked at the bacterial causes, the common ones. Always remember in your board exam, common things are common, right? Think about bacteria, think about viral, then go to non-infectious causes. Did the child just get a vaccination? Is the child dehydrated? Is the child overbundled? And the mother has bundled the kid in so many things, right? These are the things you need to start thinking about. And what are the serious bacterial infections you want to rule out in a child who is less than 3 months of age? Remember, urinary tract infection. That is what I'm saying. Even if you have a child, you do the ear exam and you see that, look, the tympanic membrane is red. So far as the child is less than 3 months of age, the least other exam you should do is a urinalysis. Why? Because UTI is the most common cause of serious bacterial infection and fever in children less than 3 months of age. At least 10% of children in this category will have urinary tract infection. Another serious bacterial infection you need to rule out is bacteremia. Has it seeped into the rest of the body? Sepsis, meningitis as well, pneumonia, osteomyelitis, and septic arthritis. This is where a lot of clinicians get into trouble, right? Check the joints, check the joints, check the joints, check the joints. Now check the skin for cellulitis. Check the joints, check the skin, check the fontanelle. Is it bulging? Listen to the lungs. Check the pee, check the urine for UTI. Okay? So now, doctors, please, I have a question. Are you tracking with me? I want to make sure that I'm not just giving facts, but we are building on it. 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 So please let me know. Is it making sense? Is it making sense? Is it making sense? Hey, doctors, is it making sense? I want to know. Let me know. Is it making sense? Before we move on to investigations, is it making sense? Yes or no? Yes or no? Yes, sir. I see the yes, sir. Yes, I like that. Dr. Sarah Maddy says, yes, doctor. Okay, good. So now let's continue. Let's continue. So you have a kid who is less than 3 months of age. We said that fever in these children, you want to treat it very seriously. Don't just give Tylenol and let the mother go. That is bad practice, right? You want to do your septic workup. Septic workup, what goes into it? Your CBC with differentials. You want to check the neutrophil count. Number 2, you want to check your blood culture to rule out bacteremia. Number 3, you want to do your urinalysis. You want to do your urine culture, right, to detect UTI. Number 4, you want to do your lumbar puncture if it points to meningitis, bulging fontanelle, irritability, right? Number 5, you want to do your chest x-ray if there are any respiratory signs. The breathing is fast, there's tachypnea, there's lower chest indrawing, there's sternocleidomastoid issues, there's flaring of the align AC. The align AC is going boom, 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 boom. You want to check that. And then you also want to do your HSV, PCR, and culture. If you see any vesicular rash in the kid, if the kid is presenting with seizures, if there's irritability, you want to pay attention to these things. Doctors, please, are we good? Septic workup. So when you talk about septic workup in pediatrics, these are the things we're talking about: CBC, blood culture, urinalysis, lumbar puncture, chest x-ray, HSV, PCR, and culture. You want to do these things so that when you go into the MCC exam, you come across as fully prepared and no one can beat you. No one can trick you. Fever in a child who is less than 3 months. So this is the point I want to make. If in your question stem, you are even told that the source of the fever is otitis media, please still rule out the possibility of occult bacteremia. And you must also rule out UTI. So far as the child is less than 3 months, do these things. Do them. So, you remember the categorization I was telling you about? Management principles. So this one, if you like, take a screenshot. I'm going to give you a nice smile. Take a screenshot right now. Take a screenshot. This is very important. If the child is less than 28 days, admit all of them. But so far as they have fever, admit them. For sepsis workup, including blood, urine, CSF cultures, and start them on empiric IV antibiotics. Doctors, please don't miss this in your practice in board exam. Don't miss it. Child less than 28 days, admit for sepsis workup. So even if you are sleeping and Dr. Broni asks you, the child is 2 weeks, has a fever. Hey, Dr. Broni, I remember in the webinar you said, I need to admit this patient right away. Child is between 29 to 60 days. Full or partial workup depend on the appearance and risk stratification, right? So there's a way we do it. Take your time after this class to read about the Rochester criteria and the Philadelphia criteria. I'm going to give that as an assignment. I'm typing it in the comment section. Rochester criteria. And then another criteria is what we call the Philadelphia criteria. I'm typing that in the comment section as well. Awesome. And then if the child is from 61 days to 90 days, evaluate on a case-by-case basis. Low-risk infants may be observed outpatient after testing. But don't forget, in all these people, one test you don't want to miss is a urinalysis. One test you don't want to miss. But for those who are less than 28 days, doc, they come in with fever, please Admit. Okay? Admit these patients, please. I beg you, admit. Now, quick one. This is a quick slide I want you to also appreciate. What empiric antibiotics do we give in these children? Can do ampicillin, cefotaxime. This will cover GBS, Listeria, E. coli. And if you suspect HSV, then you want to add on acyclovir. Okay? So ampicillin, cefotaxime. Simple. The child comes, you do the weight-based calculation. But you don't need to know weight-based calculations for the MCQ one. But you just need to know the names of the antibiotics. So ampicillin plus cefotaxime. If there are any vesicles, add acyclovir. Boom, you are done. Ampicillin plus cefotaxime. This will cover GBS. This will cover Listeria. This will cover E. coli. The 3 top mosquitoes, right? And then add acyclovir if you suspect HSV. So, I want to give you some clinical pearls. In a child who is less than 3 months of age and the child has fever, that child has sepsis until proven otherwise. Let me say it again. That child has sepsis until proven otherwise. Number 2, never ignore irritability or poor feeding. Number 3, in children who are less than 3 months of age, full septic workup, even if acute otitis media or other minor source of the infection is present. Number 4, do not delay empiric treatment, cefotaxime plus ampicillin plus acyclovir if I'm suspecting HSV. Please remember these. Do not delay empiric treatment for lumbar puncture or imaging. And number 5, fever itself does not cause brain damage. So you need to learn how to reassure the parents. We're going to do our active recall. How was the class? Remember, we are entering the next phase of the class, which is the active recall. But so far, how has the class been? I want to hear your input. How has the class been? I want to hear your input. Fever in children. Okay? Fever in children. You must know how to master it. Doctors, as I said, you may pick your Toronto notes, but you need to be guided. What are the things I need to know? What are the things I need to know? If you don't know what you need to know, I'm sorry. Right? You need to know stuff. So tonight, we have a class. Even though we are having a class this morning, we have another class tonight in MCQ 1. Okay? And the last batch of people who are writing the exam is coming to an end. By October 22nd, the last batch, is it October 22nd, October 24th? The last batch for the year would have written the exam. And the next batch will start in January to February. And then it goes on and on and on next year. So we are here to support you. These are the nuances we let you pick up. It's not just about reading the book. It's about knowing the principles and how to go about it. You're going to get support in our WhatsApp community. You're going to get a question bank in your portal. You're going to get what we call med bullets, which is your revision, right, for the final exam. So in 10 minutes, every 10 minutes, you're reviewing 10 topics. So if you do 1 hour of med bullets, that means you've reviewed 60 topics. And you ask me how it is done, the MedCognito guys will tell you. Okay? Every 2 weeks, we have a mock exam. And you also have a question bank you are doing at home on your own. And then we also have something we call med drills, which is every month we do a fast-paced review of concepts as well. You may tell me, oh, Dr. Broni, I've been an old graduate. I've not studied for a very long time. I always tell them, last week, some people registered. I told them, look, give yourself 2 weeks. You'll be surprised at the amount of knowledge you will pump into you. Because we are having this class on Sunday mornings. We have another class on Sunday evenings. You have another live class on Thursday evenings. Every class is recorded, so you can also watch it. So in case you even miss a class, you can go back and watch it. Maybe you were working or you were traveling, right? You get question banks to deal with. Doctors, it's a full package at MedCognito. And remember that currently we are running a promo. Okay? We are running a promo. A one-time payment is only 1,997. One time. You make it a payment, you get access to all these things. All these things. So now, let's jump in and go in to do the active recall before we call the class of first one. What is the gold standard for core body temperature measurement? What's the gold standard for core body temperature measurement? What's the gold standard for core body temperature measurement? Gold standard, gold standard. Beautiful, beautiful. Dr. Joanna De Cruz says rectal temperature. This is how med bullets look like, right? This is how med bullets look like. After you've learned everything in class and everything, this is how. So med bullet is like active recall. Med bullet is like that. Okay, so the correct answer is rectal thermometry. Beautiful. Next one. What's the best method for measuring temperature in children who are less than 4 weeks old? What's the best method for measuring temperature in children who are less than 4 weeks old? 4 weeks old. 4 weeks old. Who are less than 4 weeks old. I mentioned it in class. Who are less than 4 weeks old. What's the best method? Especially they are uncooperative. Good. Auxiliary, Dr. Benedicta, electronic auxiliary thermometry. Beautiful. Next one. Let's go. We are doing a med drill right now. What's the contraindication for rectal temperature measurement in children? Contraindication for rectal temperature measurement in children. Let's go. Contraindication for rectal temperature measurement in children. Please, let's go. Tell me something. Neutropenia. Beautiful. Dr. Joanna is on fire. Neutropenia. Good. Next question. Most common serious bacterial infection in infants. Let's go. Most common serious bacterial infection in infants. Most common serious bacterial infection in infants. Tell me something. Most common serious bacterial infection. Most common. Please, I mentioned this in class. Most common. I'm not saying most common organism. Most common serious bacterial infection. The most common. Good. People were tricked. They were thinking about the most common organism. The most common serious bacterial infection. No, Dr. Eno, it's not meningitis. No. It's UTI. Most common neonatal pathogen. Okay, good. Now let's go for that. Most common neonatal pathogen. What's the correct answer? Most common neonatal pathogen. What's the correct answer? GBS. Group B, streptococcus. So doctors, thank you very much. It was a wonderful time spending 1 hour, 10 minutes with you this afternoon to study this very important objective. Please, this is my own phone number. +1 306 891 5649. +1 306 891 5649. Send me a message right now. I'm going to spend the next 2 to 3 hours responding to messages which come, and then after that, I'll shut down my phone for family time. So 306 891 5649. You want to enroll? You want to take advantage of the promo we are doing right now? Call me right now, and let's get talking. Call me right away. 306 891 5649. 306 891 5649. Somebody just sent me a message. Is the class tonight free? No, the class tonight is not free. It's a paid class. So you can take advantage of that. You can take advantage of that and just make the one-time payment, and you'll be enrolled in a class right away. +1 306-891-5649. Doctor, thank you very much. See you on the other side of success. I love you all. Please make sure that you are studying content which is relevant so you can be prepared to practice in the Canadian context. God bless you. Stay safe. Keep the fire burning. Bye-bye. 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 Bye-bye.